Sorry for the initial review of the earlier slide. Right, thank you for having me and for listening to me. My biggest problem is hands off for me. My first slide, and I'll continue talking about it for hours. I need to proceed there to make sure I don't go beyond time. I'm honored to be here really at this audience of university lecturers and people from the Klang Valley and from small town, Johor. You heard that I was approaching a small town guy. Right. I started my society work. I started to build no society for my hospital, and I thought society was all about rehabilitation. Because I was posted in the mental hospital, where the patients were not talking to you. They were doing their own business. They were doing nothing really. Just for abo lah, and I thought that they need some form of rehabilitation. And the people there in the Kampung Mental Hospital, there were 2,000 patients at the time. It was way back in 1987, before I joined the master's program. And people that say they need some work, so I bought some jangkol, some seeds, and together with a group of 60 patients, we started to do some work and planted some seeds, and they sold the vegetable. And they're quite happy doing it because they grow in the sun and so on. The text they have used. Okay, and from there, 1987 as well, the Pengarah Hospital went away on leave for some training for 3 months, and they appointed me because the only one who wanted to talk and say something needs to be done, and appointed me as Action Pengarah. Action Pengarah, I didn't know anything. It was the criteria. I'm not still surgery, I got my part 1 surgery. So I wanted to do surgery, but by faith and happenstance, I happened to be a psychiatrist. I used to go on my non-on-call days to do surgery in the hospital. So they still remember me and that. Anyway, so when he left for Japan, he said, "You be the Action Pengarah for 3 months." So I want the Action Pengarah. Action because I thought I knew everything, I didn't know anything. So they said, one day, a guy came and said, "What do you need in this hospital?" So I came, "You need to do large-scale chicken farming." So I said, "We need to do large-scale chicken farming." I was like, perfect. He said, "We need the hospital to buy the chicken. We need the hospital to buy the chicken." So this Timbalan PKSU was psychologically minded. "Are you sure you can do it?" So briefly, I normally do things first and I apologize. Okay, I'll tell you the story. I do first and I apologize. Yes, you can do it. You don't have any knowledge about chicken farming and things like that. So after 1 month, yes, beginning such a date, the patient, the Badan Kebajikan Hospital Perman will supply chicken to the hospital. It's a new contract. And suddenly we have to look at this contract. How much of chicken is required to supply the hospital? 1,000 kilograms per week. And we have to go to the board. We had 3 months to do that. We had to go to the board, get the people of the Islati Johor, they was chicken farming people. We called them in and they started to traffic for us. They said, "You need to have on a rotational basis about 6 cooks. You masuk anak ayam lagi, and this 6 cooks, the next week will be that one, the next week, so it's a 6-week rotation. Then we will supply. And depending on the death rate, so I don't let me talk about this. In my former life, I was not a chicken buddy. So if you control your death rate, you need to take in about 1,200 chicks. Okay, so that you can get about 1,000 birds, which will be about 700, 800 birds. Right, and not only that, we also have to learn about having eggs, chicken eggs. So the short story body was a group of professionals who thought that patients needed some work, and at the end of the day, we produced. So 3 years, we supplied the hospital with eggs and chicken, but unfortunately, none of the patients could do chicken farming. None of the patients. If I had the foresight I have now, Permai would have been the Kentucky Fried Chicken. Because we had the experience at that time, 87, 90. Okay? Anyway, so all those stopped. I went to university one time, and the ideas of rehabilitation in university is crap. I'm sorry to say, even in CYM. Okay, the biggest rehab is the daycare, which is absolute rubbish. So shelter workshop is zero as far as Thank you for asking for the recognition. I'm the guru or rehab, okay? So I can say whatever I like. But anyway, I don't have the evidence, but you can talk to, you can ask me what evidence I can produce. It doesn't work, I can show you that it doesn't work. The shelter workshop doesn't work. Full stop. So why invest money in shelter workshop in something that doesn't work? Because today's best practice. Right? And the reason is because when you go to any model or service delivery, permai, bahagia, many slides are different. It's a good model of service delivery, but confined to a very different population. To study UCMI, good model. Not because for Christian and happy my friend, but it's a good model. If you study relapse rate, people who go to UCMI low. So something is happening there, but the cost will be high. Right? So we in Malaysia, we don't have a good model of service delivery. Wherever I go, I was in GKL, I was chairman of the QA committee, and every single QA workshop I do, the first study they say is high relax rate, high relax rate, high relax rate. What's the relax rate? 70%, 80%. Okay? Number two, services does not meet the healthcare needs, like what I did. Chicken farms, it most makes shocks me. But somebody decided that chicken farming is the way to go. We invested a lot of time and effort, but not the patients. We did not look into families and consumers. I'm a family member. My cousin is a bipolar illness. After 20 years of managing him, because there was some crisis with the maid, he wanted the maid to marry the maid refused, and he attacked all of us, so we had to admit the went to hospital. And then they were ready for the maid to go home to Indonesia, waiting for a new maid. It took about 3 months, so we wanted him to be there for about 3 months. And every week we'll be going, of course it's on the weekend. Right? And then we don't see the doctor. So the doctor wrote a nasty letter, please come and see, don't, please come and see, don't dump your family in the mental hospital. So we took leave and went, doctor nak duduk. This is true, me and my cousin, tak sempat duduk. You family members always reject your patient. Stunned. They said, you doctor, you're a young, I was a psychiatrist. You're a young doctor, please don't say what you don't know. Thank you very much. What do you want? When he came back, alright, we gave him a time frame. So, no, they didn't listen what was our problem. And unfortunately, society, evidence-based is the last thought. Prophet Hakim did bring up evidences. I can challenge you. In Malaysia, I've done that study. How many evidence-based psychosocial services has been done? You'll be surprised, almost none. Right? Okay. This is the last mental hospital. This is Birmingham where I was trained. There were 5 such behemoths. Okay? By the time I went there, we had closed down 3, so we were in the process of closing down 2 more. One was Polymore, High Croft Hospital, and the other one is Lady Right, and lo and behold, if you look at this design, the same design that almost all mental hospitals do. This is a design that was done 1864. And Hospital Permai, Hospital Bahagia follows the design. And you think the newer ones, Hospital Sentosa, built in 1958, also something like this. Hospital Bukit Padang, you thought these people would learn something. Right? You will have, as the road comes, you will have a big administration building. You don't see general hospital. You have to see the administrator first. The administrator decide things are good, then when you go enter lah always. Dulu lah. Now you can walk in anytime you like. Right? Kalau dulu kena jumpa puan Tom Karah tu, baru can I go there and care. Kalau Tom Karah telefon, patient semua ada bantu tak? Kalau ada bantu, you can't say, oh sorry, we have got a crisis in front of you. Outside of that excuse. This is too short. This is you must see a book on the architecture of intimidation. Okay, the Nazis are very good at that. Big buildings, huge facade, and entrance to scare people, show the power. That's why the White House is white and powerful. And you have the President of America, the only office in the world that's over today. Right? Because why is it over? You put the chair there, he's the only one who is facing the room. Kalau square kan, ada one yang tak nampak. So that's the architecture, and this is how people are being treated. We do have that. Okay, so the mental hospital is an outdated paradigm. Okay, not suited at healthcare, no evidence base. When I went to Kuching, right, we thought that it's a so-called, when it was built under the British, this is the modern, this is the latest in terms of mental health intervention. But at the end of the day, right, there were 122 patients who did not show up. The Center for TB, I'm very good at TB. When I went to Purban, because I had experience in Kuching, we managed to pick up 40 new TB cases. And think that we just finished the last patient September. Then I had the foresight, we must re-screen. We re-screen, we pick up 2 more. And one we re-screened and missed. In the forensic ward died. TB. So those are the effects of institutionalization. You think our patients are overweight, only in the forensic ward they're overweight because everybody is on colonoscopy and colonoscopy because of the forensic issues. I've got 140 patients who are malnourished. Below 30 kilograms. Sorry, below 35 kilograms, BMI below 17. 140. Okay, we are moving to a new hospital. They give us so-called independent living quarter, which is very nice. But we only find 10 patients who are really independent of the 700. So, if that's the process of institutionalization, it's nothing new. If you read about it, New York State Hospital 1960 in this time, nobody wants to read it. Right? I'm glad that Prof. Hussein championing the fact. I thought I was the only one who said, do not send patients to the mental hospital. And we have our friends from University Maya. Rivers have, when he started it, it was not so well. He was going against the tide of the society, right? Now it should be alright. We are saying, don't send patients there. When you send them for a short while, send them back. That's your message, isn't it? Rivers have, you can send them if you have some real issues, but send them back to me. I'll look after that. That's the message that we have. Do not send patients to the mental hospital. And in the mental hospital, you still get abuse and violation of human rights. You still do. Right? You need champion. You need somebody really like me. I say, any person who's restrained is a medical emergency. The specialist must be that. So with that one rule, we still stop. If not, every other patient will be restrained. Recently, a patient died in the hospital Bakar. Was strangled by restraint. 2 female patients were restrained, one released the restraint and strangled the other 2 patients. It cannot survive. That's recently. Right? So we thought we send the patient where they come back late. Okay, because a lot of things happen at night in the mental hospital. And it's very costly, I am the largest landowner in Malaysia. I manage 700 acres of land in Johor, in Iskandar region, prime area. Okay, so 600, nothing has been there. The one that you see is only 70 acres. I've got another 600 acres hidden as forest land. So maybe you take donation up, got cost, fine, no problem. Next time we have invitation to the name. Okay. The cost of maintaining this hospital is a lot. It's more than the cost of salaries and the cost of medication. Maintaining this hospital is double that of the salaries and 10 times that of medication. Alright? So it's immense. Okay, let's talk about services that meet the needs. What are the needs? This is a survey that I did in Johor because we want to know how many patients are homeless. So this is what we found. At that time, because it's schizophrenia, 8%, this is a point variable study, only 8% was in the hospital. 16% can come to the APS, clinic center, and including psychiatric specialist outpatient clinic. In Johor, all the health centers in Johor Bahru, all the health centers receive psychiatric patients. There are 3 specialist clinics. One in the mental hospital, 2 in the general hospital. But look at this. 52% disease support. We've got 600 patients who are on home treatment, case management. So my safety staff doing this. We've got 3 verticals, 4 now, with a chief driver, nurse, and attendant who goes and gives injection to the patient's house. And this is the boring figure. 24% don't know where they are. Despite that, we have people that came to the hospital and we do not know where they are. So now there's another target that come up with no defaulters, 0 default rate. So that started January 2010. So the defaulters will start before. We do that, but that's the number. We must reduce this. So that's the need that you have to look at. Meaning to say that you must support this and this and make sure this doesn't come back like Prof. Hatim says. Eventually they'll relax, because if they are not in contact with service, they will relax. And you don't want them to relapse back. When you say they kill themselves or they kill others, you don't want them to do that. Right, what do the patients say? Patients say, treat me with respect. This is a survey we did with 500 service users in Johor. Treat me with respect and dignity. Help me with my house. Housing lah, they want some benefit. Anyway, kalau ada alam rumah, allowance OKU, allowance OKU bekerja, they want that. They want you to help them with that, filling the form, signing, make it easy for you. They want to know what medication they are on and what illness, the psychoeducation part. They want to know how to get the services. In your house, no problem. We've got 3 centers that open 24 hours. The mental hospital, Hospital Sultan Ismail, and Hospital Sultan Aminah. So in the name of the hospital, I use usually it's not Hospital Kuala Sultan Aminah, Hospital Sultan Admiral. Nama saya itu Hospital Kuala Sultan Aminah. Alright, anyway, and they want alternatives to this. If they don't want to come to hospital, what to do? And they want support for carers. Right? What do the carers want? This is from about 200 carers in the survey. They want jobs for their patients, for their family members. They want this revolving door, something to do so that they don't become revolving door. Also better information, also to power access. And it is sometimes we need a rest. So can you look after when we need a rest? This is what the carers say. Okay, let's look at evidence-based services. Evidence-based says that the cost is the same. When you provide this, the cost is the same. It's not really much. Right? The cost changes. From paying for the building, you're paying for the salaries and the mileage use. Right? So that's the shipping cost. Instead of what cost, mileage pays. Is it more effective? What's the relapse rate for people on community treatment? Less than 1%. So I can mention the basis of the WHO report. We published. I did this when I first was in Kuching. I was asked to prepare a paper, so I reviewed 700 patients. When I saw that it was less than 1%, I was shocked. Nowhere in the world is less than 1%. One, the argument is there are very high usage of depot, so 700 patients, 80% on depot medication. 2, the 700 patients, about 650 were living with families. 3, there are very regular contacts with the psychiatric services. Those are the 3 main reasons. So I thought it was teaching 4 because I was there. So I said he's a great guy, have some aura to reduce the vaccine. Then I went over to Kedah, they have about 200 patients. No, and behold, it's less than 1%. Okay? And then I went to Bahaya, it was less than 4% at the time. Why? The threshold for admission was low. Patient, nice longer skate admit. Okay? Patient, major skate admit. Right? So there was a high, low threshold for admission. So it's not 4%. No problem. Right. Then we went to HKF. And HKF said they have a big problem. Because the way they calculated relapse rate is different. They look at everybody who came to their hospital. That's it. I asked them to relook at their rate of work. They had 800 patients that they look after in community care. So when you ask them to do it, they say, oh, those white areas very high. Those areas under our care very low. So we calculated, exclude the white area. White areas, so they have a unique way of looking of seeing these other patients to look after. Because KL being quite densely populated, a 3-mile radius would be about more than Johor Bahru. Okay? So they look at it, the 800 patients that they were looking after was less than 1%. It's quite a universal finding that the relaxing is very low. Okay? And with this, there's increased satisfaction, better engagement, and more social inclusion. And this is the recommendation that WHO gave way back in 2001. So do we have all these available? Yes. Treatment in primary care. In Malaysia, about more than 80% of primary care gives treatment for the mental ill. And we have a list of 60 essential medications at clinic kesihatan, including the injections. Make the psychotropic drug available. This is a challenge. We do have that, but the atypicals is a challenge. The newer ones is a challenge. Care in the community, meaning to say we want patients to be treated at home as much as possible. It's happening in spots. Like I mentioned, UM had difficulty trying to get it, but not able to. We've done it in Klang, HKL, and yang lain belum buat lagi. Selayang is just starting. UKM dah ada. That's the criteria. Public education, on and off. We now have from last year, Mental Health Promotion Board in the Ministry of Health, check on the minister. Last Wednesday was the meeting. You must have read that the minister gave a press conference saying that 5% of children are depressed, severely depressed. Right? That is the Mental Health Promotion Board, which proposes public education programs. Community, I started the first family support group way back in 2002. And now we have family support groups almost everywhere. I mean, we run their own public family support group programs. I was in other staff on Thursday. There are 9 family support group meetings. Johor has it every week. The JP and Mua. Ipoh has it every month. Penang has it every 2 months. Do we have national policy? Yes. Malaysia has got this. Do we have a plan to develop human resources? We don't. Are we linking with other sectors? We are not. Are we monitoring it? Yes, we've got nice indicators to look at. Relaxing, that's why we know how much our relaxing is. Okay, this is I won't go to this. But what I'm trying to say is that it's not just all about community. We need a balance. Some places do need to get it. It's usually about 14%, 1/4. In some centers, up to 50% of patients get admitted. Doesn't really matter, because the admission is part of the patient's life cycle. They need admission sometimes. Make the admission as quick as possible and as short as possible. It's an experience that they must enjoy. Unfortunately, they don't. A lot of the time, they do not enjoy the experience of the admission. Right? And the services must be close to home. Interventions for symptoms, specific individual needs, less reliance on the large mental hospital. The role of the large mental hospital should change. No more acute admissions. And you can do this actually. In Johor, what I have done is that every single hospital admits a hyper patients in Johor. So we've got 10 hospitals. 1, 2, 3, 4, 6 specialist hospitals and 4 non-specialist hospitals. Every single one admits a hyper. And with that, we have reduced the number from 2009, 1004 to 950. And it's done by the reduction in acute beds. And Prof. Hussain has seen that. We have closed many wards. We are still closing. Now we function, we had 3 acute wards. And he came, there was 2, now there was only 1 acute. It's 60 bedded ward, but the patient are never more than 45. We can do that because admissions are all over the state. Then 45 admissions. And we have dedicated per shift, because we are able to increase the work per shift. We are able to have 30 staff. 1 sister, nursing sister per shift. Right? So we introduce concepts like 1-to-1 nursing, 2-to-1 nursing, and for patients very distant, we can allocate 2 nurses to high dependency nursing, and no restraints, no seclusions. Right? You don't have restraints the last 2 years in hospital. So those are the things that you can do actually, and to reduce this. So when you want to do community care, this is the first step. And what we do is stop the admissions by each catchment areas, each hospital taking the people around them. Whoever wants to refer cases to you, pick up the phone and ask them why. Okay, sometimes that alone will stop admissions. Oh, my ward is very busy, it's overfull. Why don't you discuss some of the patients that can be discussed first? Just take one, ask question. Can you do that? You do that and then call me back. We don't get call back. And admission locally first, but we need this. We do need the patient number, certain number of beds for medium care. Patients cannot go up there. There are some patients like that, we need to allocate those beds. Right, and this is what we have been successful in the last 2 years. No more long stays. There are 2 types of long stay patients. The new long stays. I published a paper way back in 1995 in on these new long stays. We know who they are. Young, familyless, they don't have families. Substance abuse. You know them early, you know them they're going to stay. If you put them in the mental hospital, they stay there very long. They end up complaining. Find alternatives very quickly for them. The cut-off is 3 months. Don't make them stay longer than 3 months. So we have not had that for quite some time. Right? So that's why we're able to make sure that there are no long stay institutions. So this is what I mentioned. For potential to be long stay, the young, raw diagnosis patients, social issue patients, make sure the care is more intensive. For the old long stays, you have to make their life better. Just provide something better for them, because in most studies, what happens is that in the TAP study, in the Victorian study, if you relocate the old long stays, their life is not going to get better. They will remain the same. They don't have friends, the symptoms remain the same. They probably have a bigger space, but they still don't know how to go to the shop. And this is true. For my old long stays, they are very disabled. You're crying, in fact, to see what the previous people have done by ignoring this group. It's just neglect. You just put one attendant there, hoping things will happen, nothing will happen. Okay, there are 4 things that you need to do in community for people with schizophrenia. One is to give the best possible education. Let me ask you, what is the best medical education? From Admiral, you can do a list. What is the best education? Free. One is free. Yes, probably not. Or maybe in KTF, all medications are free.
Observation.
Yes.
The best medication would be the medication the patient would like to take.
Thank you very much. You are the one. On the middle. Exactly right. Doctors don't know this. I've asked this to doctors, they say, they go by evidence. You're right. What the patient wants to take is the best. Because it's all about complying. Complying is what you want to take. If you like it, you take it. And we know people don't take medication because 1/3 don't take because genetic medication will work. 1/6 don't take because of side effects. But half don't take because of the reason you mentioned earlier. Family members say money to pay, church members say money to pay. They find it difficult to go. They don't like the doctor that's giving them the medication. Other is a logistic reason. So whatever the patient wants to take, that's the best. Right? That's number 1. Number 2, you need to educate patients and families. People mentioned that. There's no way to avoid that. You must have this patient education as well as family education. You cannot have one or the other. You must have both. That's number 2. And number 3, you must have something for the patient. And now I believe is giving them work. And work is called supported employment. I think I'll talk about it later on. Okay? And there's a 4th one, which if they cannot work, they have something else. It's called multimodal. It's not one type of rehabilitation, it's at least 2 types. What are the 2 types that you must have? This is must have. You must have education program for patients and families. That's the purpose to make the cake, right? You must have work program. Okay, that's the button. Then only jadi cake. Kalau tidak, tak ada cake. The medication is a gula. So you have a basic cake there. The rest is all IC, different types of cake. We have flour, sugar, butter and eggs. There's the medication, patient education, family education, and work program. Okay? The rest are all like what I said, cognitive therapy. I can do it, but I'm alone. I can only do one patient or two people. I think in Malaysia, one or two more people can do it. So you can forget it in Malaysia. Social skills training, yes, but that should be the first part. You know what social skills training is teaching people how to talk to one another. It's interaction. So in most people, if you start early with schizophrenia, they have not lost that skill yet. So if they have not lost it, don't teach it. Okay? Daily living. A lot of people with schizophrenia who first contact still able to comb their hair, brush their teeth, they're still able to do that. And number one. Number two, you treat their symptoms that comes naturally because they've been taught that before. So you don't need to teach them. Cooking. How many men can cook? Normal men. Not many. Okay. Not many. My son is a doctor. I asked him to cook rice one day, and he said, okay, done. Bagi kesempatan nak ambil satu gelas gula letak 2 gelas air. Basuh sikit minyak, basuh dah. And what happened? We came back, rice not cooked. You know what? Tak tekan ke? Oh, nak kena tekan ke? All inside, never put rice in the rice, only side. So my patients in the mental hospital, because they were going to move to this nice complex for independent living, 400 rooms, nice rooms given for patients, and fully equipped like a modern house apartment, fully equipped with a kitchen, with all utensils. We trained for 2 years, 150 patients. For 2 years, every day, cooking and so on. Only 10 can really cook. The rest will take the knife and look at the knife and the vegetable. That at least 4 hours. And say, hey Mat, potong. Then they potong. And then they sit quiet like a robot. So they can't cook. They cannot cook. Right? And no point teaching them. Right? So don't worry about those things. We need to look into that later on. So multimodal says that you must not only depend on one type of rehabilitation, it must be a combination. Okay? What's the combination that must be done? This is the whole list of that Hatim has given. What you need to focus on is this: self-help groups, patients and families. So it's not in order. Illness management is psychoeducation, but more focused. That means the patient now becoming empowered to teach other people. And this is my mantra nowadays: supported employment. And you notice anywhere when this is a shelter workshop? Nowhere. Because supported employment has been compared as a shelter workshop. If you're looking at people, the work is getting back to community. Shelter workshop, don't put them back into the community. Daycare, don't put them back into the community. So you have to ask for a supported employment to them. I hope I've got the supported employment. Okay. So it's another slide. So what I did in Permai was that when I went to Permai, when I went to Kuching, the idea was already there because I was started to shelter workshop, of course. Try to get in. My role in rehabilitation was shelter workshop. You know, the chicken project is sheltered. We do everything. Patients are started. We pay the patients a token. Okay? The tokens are many kinds: money, cigarettes, tobacco, all the fun stuff, biscuits, macam budak. Then I migrated a little bit upwards. We worked with a Japanese company for making toys, stuffed toys, which is exported using KL. And we did that, patients earned a little bit more, but miserable until they fall in. Not enough to survive. Okay, then, so I thought it was shelter workshop. Then I went to UK and I saw this Vita. I was involved with Vita, British Vita, okay. The government gives us a lot of projects. But what the people do is work groups, job groups, to come in, sit down, and talk about together. Like that. None of them wants to go. In the end, The OTs have to find normal people to go and work. And who are they? The Pakistanis and the Banglas. But not come back. The patients are not working. They don't want to work. Okay. Then we were exposed to these social enterprises in Ethiopia. And this is very interesting. It's not there. What is there? And you have it in your eyes in your hand. Look at it. And you know how the patients are. They're very different from other patients. Correct? They run their own business. They're so proud. They manage their own money. They are their own managers. And that's social enterprise. In fact, in Italy, they believe that is their money. You get people, patients and normal people together, let them talk about business, give them some feeding run, help them to launch their business and see how they go. And think of it like business. If you're a businessman, how many percent of businesses fail? Yes, any businessman? No, 50% fail in the first year. Right? But we don't see as failure. We see the successes. They're able to sit down. They're able to write a business proposal. They're able to get funding. They're able to convince people. Those are all skills that they learn. We don't see it as failure. So that's the job of the nation effective institutions. So I'm quite happy to give our funds for that. And we've got a lot of successes of them. Right? So that's social enterprises. A lot of
Doctor,
yeah.
can I support your point here with my observation?
Yeah.
These social support enterprises is the ideal way to help the patient. Because patients, however you train them for the job market, will come back to you. Reason is the job market is not ideal for them. They cannot handle people around them. They cannot handle the stress. They cannot handle the ridicule, all that. So they come back to you. But if you use these social enterprises to train them to be self-reliant in a business that is they are able to handle, that is the way to go.
I agree with your point to a certain extent. Social enterprises is one way to go. There is a society in Hong Kong called the New Life Society, which focuses on social enterprises for society issues. So they are running a non-profit and business empire of 130 people in Hong Kong and all over Australia. And they've got 100 odd social enterprises all over Hong Kong. But that shouldn't be the only way. That's one way. But I will have to dispute with you about the employment now. Okay? Because the key is the support. You did mention all those things correctly. That if they are left alone, they will be stressed, they are having problems interacting with new people, with their supervisors, with their employer, with their colleagues at work. If you leave them alone, if you support them on a daily basis until they are well, they will do well. They will do well, and the rate that we have in 1 month, after 2 years, after 1.5 years, is that 40% will remain at work. So we now have a number of 130 people who have continued to be working for the last one. We started 2009, so for the last 2 years. So the key is the support, and there's a huge research done in Europe which says the support must be done on a very regular basis, no close. There are a few principles. I'm sorry I didn't have those slides. The one principle is zero exclusion. Just like Air Asia, everybody can fly. Here, everybody can work. There's no exclusion that you are schizophrenic, you are negative, simply of your society, you cannot. No. Everybody can work. You must aim for that. Number one. Number two, almost no assessment. You don't want any barrier for problems. Since you're not good, Kadir said, I'm the guru, this fellow cannot work, this fellow no. It's minimum assessment. You just ask one question. And what is that question? You want to work? Mau kerja atau tak mau kerja? That's all. After that, it's just interest. Apa kerja nak? I nak pakai uniform, saya suka juga. I tak nak tengok orang, saya cuci jangan. I don't treat people. I nak buku orang banyak-banyak, waiter. It depends on your qualification, right? The next step, getting the job is very easy. If you're baru, you've got plenty of jobs. Now we don't have customers because almost all the jobs of customers are filled. We have plenty of jobs. So we are looking for patients. Okay, that's one. So you start looking for the jobs, they are not there. And this is for the group of patients. For most of our patients, in Johor Bahru is Form 5 anymore. They have not finished at Form 5, so they will look at SRP level. So skilled workers is not the thing that they are looking for. They are looking for cleaners, security guards, waiters, and so on. Kalau pandai masak, harga tinggi. Masak kat kedai lah, kedai mamak kan harga tinggi. So we got one who can live for teacher night, we place them outside 1,500. But we negotiate, the one 1,500. Give you 1,001. Why? The free medication, please. Medication free. Why? Because OKU, if they are labeled OKU and they work, they get a top up of 300 ringgit from kebajikan. Government pay them 300 ringgit. So 1,004 becomes 1,000. 1,001 becomes 1,004. 300 from government. We want to maintain that. They want the government to see yes, you're still okay. They are like because I want the budget for kebajikan to be given for OKU mental. And for those who are working. We want to show that there are people who are working. So they will be given. It's all statistics. They monitor it. If they are good enough, they can own a restaurant, so be it. Right. So I agree with you, we have to do both. We cannot do one or the other. Both must be done. But it must be done social enterprise method, where you get, like your cafe, a group of patients, sit down with some OT and some good business-minded people, give them a place, start them off and let them alone. We started the canteen like that. The canteen was run by the hospital staff. And now it's totally run by 100% by patients. The last one, you had a meeting, one staff was making drinks. Why? Because the patients are pandai sangat. So after 1 or 2 years, the patient said, I think I'm skilled enough. So we terminated the contract of the staff, they're looking after. So no problem. The kedai sehat, or one country shop, which caters for general goods for the hospital staff and nurses and new staff for training. They had a staff who was there all the time. Now 2 patients running it, fully paid. The profit is not that much. Kedai runcit memang kalau general tu tak banyak sangat profit there, but they earn the profit. And to me the profit is the patient salary. One patient earns 1,200, another earns 800 from the kedai. Okay, so that's the social enterprise. So my main idea is all these you need to mix it up in the bowl to see which is suitable for the patient. And you're right, you need to think about social enterprises. In Italy, that's what they do. There's a think tank, family members, patients, psychiatrists, psychologists, occupational sit down in a table. Okay, the psychiatrists are still delegated, they cannot do anything. They just listen. Okay. That's a joke, because they're all equal partners there. And their main expertise is business, setting up business. And which are viable. They talk about what's viable business and what's not viable. And they believe every patient must have a chance for getting involved in business. Why in Italy it works? Because Italy is very high in self-employment. So it's Malaysia. We are all government employees. So we think everybody is government employees. How many government employees are there in Malaysia? 1 million. 1.3 million. What's the population of Malaysia? 30 million. About 29 million, I think. So that means 28 million are employed other places. Let's say half, 50 million employed elsewhere. And of these, I don't know the statistics, a lot of statistics. Only in Malaysia we find every corner taken up by going some seller, buy a burger, what company who sells burger, right? You do also see that in Italy to a small extent. But in Malaysia, it's glorified. In Malaysia, mana-mana pergi bakso. Kalau Malaysia lagi pula, dia tarik dari rumah ke rumah kan. From house to house, they peddle food, they peddle jamu, so lagi orang peddle roti, ice cream semua kan. Ice cream in Malaysia together. So don't underestimate the value of such employer. And there's one good business, all you need is a robot. Set and right. the one that cut my house is the Myanmar guy. Okay, he started cutting my house, then he cut the neighbor, then the neighbor. Now he's employing another Myanmar. Dia employ. Kan, kita dalam apa ni, Datuk Syamsuddin kata they can become employers. So it's difficult to get the putih program. Right, so I'm just sorry, I'm digressing. So you need to talk and choose. And my current thinking is the one that you choose is number one, education. That one you cannot run away from. Educate the family, educate the patient. That's a must. And this work program, you choose what work program is needed. For me, see what Hakim saying, you want to bring them to recovery. If you don't want them to recover, put them in shelter. Then they will have to. So just deciding what you want them to do. You want them to recover, put them at supported employment. And the key is what you mentioned, sir, that they need to be supported. Because you know when they go to work, they'll be stressed, they'll be anxious, they'll be worried, they'll be embarrassed. But you need people to help them come to them. It's all about stress management, helping them increase coping, and so on. So somebody must do that on a one-to-one basis. That is good. And as you rightly pointed out, we need to get people to generate money because money is important for independence. Right? Okay, and to do this, why are we doing this? Because we want this. We want them to make decisions. We want them to have friends outside mental health. We want them to get an important role. We want them to know how to use medication. We want them to have increase in the intelligence level. Last Hari Raya, I attended a Hari Raya gathering which was conducted by these two officers. They did everything. So the speaker bagi pantun. Every time they bagi pantun. Saya nak jawab tak boleh. Tak boleh. Okay. And they have this new thing. They have this sense of self. They can sit down at the meeting. I think, sir, dia puan, saya nak puan begini tak boleh jalan. Tak ada. Kita nak tengok dulu. So that's the way that I was waiting for. That was very that he's able to see that. So how do you do this? Let them trust themselves, allow them to make choices, help them believe that they can make it better, achieve full potential, treat them as human beings and as people with rights. That appreciate that they're trying to make some meaning, help them have a voice of their own. Validate their feelings, and whatever they're feeling is not wrong, follow up their ambitions and relate it. So those are the key things that you want to help your patients to do. At the end of the day, they will tell you this: talk to me about my illness, talk to me about my education. Allow me some choices, if possible. Talk to my family. Help me with jobs. They keep saying jobs. Because if you put them in daycare, they still want jobs. And benefits coming at the okay, you help them with this. Listen to me, trust me. This is what my patients are in the job program tell me. Okay? When they recover, when they're well, when they're at that level of the canteen manager, they say, okay, I'm now the canteen manager, I'm happy with it, I know when I'm well and when I'm well, I can make decisions, I feel great, I have more connections, you know what my canteen manager, what I can back and see where, so the student nurses can get better to me. I want him to be careful his policy to get. Okay, the physical health is improved, definitely. They do after themselves well, exercise and so on. And they are better people. And this is what, at the end of the day, you want to manage your people who have schizophrenia in the community. It's mainly just 4 things really. The best meditation, educate the patient, educate the family, workplace programs. Thank you very much.